Pathology of the eyes, the ears, the smelling mechanism, the taste mechanism. Start big first. Let's go with the eye. A lot of problems can happen with the eye. Terminology is important. Understanding what causes them is important. A quick overview. Again, you haven't had the eye for probably a couple of semesters. So we have the cornea on the front, the clear covering of the front. We have the sclera going around the rest of the eye, the white of your eye. We have the pupil, which is the opening in the middle of the iris. The iris is the colored part of your eye that gives you blue eyes or brown eyes. The light comes through the pupil, through the lens, which is attached to ciliary muscles, as is the iris. So the iris can open or close the pupil, and the lens can slightly change shape to accommodate near and far vision. You have the retina in the back, most concentrated right here, the fovea and the macula. Fovea is the one little place that is most dense with rods and cones. The macula has lots of them too. Less and less as you get around here, so your peripheral vision is not as acute as your straight-on vision. The retina sends all of its signals back down the optic nerve, which goes through the optic chiasm and then goes back to the occipital cortex, which is your primary visual cortex. Rods and cones. Remember the rods, you have a lot more of them. They're your night vision, your black and white vision, gray colors. Cones are bright light and colors. In the anterior chamber, you have aqueous humor, anterior aqueous, AA. In the posterior, we have vitreous humor, which is more gel-like. You're constantly producing fluid in here, and it drains out through these canals of Schlemm and exits the eye, and therefore, just kind of like your cerebrospinal fluid, you make fluid, you release it, you should keep the pressure in the eye just what it's supposed to be. Lacrimal duct over here to make tears. They're up about here. The tears wash down across your eye into the little lacrimal, canal that takes the tears actually into your sinus passages. If that gets blocked, you can have a swelling of the eye. Not the eyeball, but around the eye. You have a variety of muscles, several different pairs of muscles that move your eyes, track your eyes side to side, up and down, cross when you're coming in to view something close, and straighten when you're looking far. So, talking about some of the defects that can occur, first of all, we'll talk about a couple of eye tracking defects. So, very mechanical here. If your one set of muscles pulls harder than the others, your eyes aren't going to point the same way. Either when you track them, they will change position, or one is always pointed in the wrong direction, slightly. A strabismus is eyes that don't point in the right direction, in the same direction. So you can be cross-eyed, your eyes can point out, they can point up and down, one can be straight, one in, and that's a strabismus. A nystagmus is a jerking of the eyes, especially when you look off to the side. Turns out, actually, our eyes are always moving a tiny bit. It's so fine that we don't really see it. If you look really carefully at somebody's eyes, though, a lot of times you can see it. Those are called saccades. And it's one thing that makes us one of the best animals at seeing still objects. A lot of animals, like birds even, they get caught by cats because, you know, our cat will be sneaking up on a bird and I say, stupid bird, the cat's big, it's a bright color, you can see the cat, so we go chase the bird off so the cat won't get it. But if the cat is still, it just doesn't pick up. Like Jurassic Park, the T-Rex. He couldn't see the kids as long as they were sitting in the car. But because our eyes are moving, we actually produce the movement that we need, and we can see a cat that's sitting perfectly still. But a nystagmus is an over-jerking as the eyes move. Here's a strabismus, amblyopia, lazy eye. This, so this baby is cross-eyed. They can surgically tighten muscles and stuff. There are some things that they can do, although it's still a pretty difficult condition. One problem with the true lazy eye is that when babies are born, you don't notice really what they can see and what they can't. And so people don't notice if they are favoring one eye over the other. And often the weak eye has vision that's just as good, but their brain, they just concentrate on what they see in one eye. It'd be like if you just kind of close one eye all the time. I had that when I had my surgery over here. I had a patch over it for a while, and I got kind of used to looking out of the other eye. It wasn't fun, but when I opened this one again, it was kind of hard to reconcentrate on that part of the visual field that was coming in. And if they develop by the year 2 or 3 to the point where they have never actually noticed the vision in this side because they've concentrated on their dominant eye, the other eye will start to drift. And it's called lazy, not only because it's not doing its job, but because it kind of falls out of position just slightly. And the best thing to do, of course, is do the visual test as early as is practical on a kid. And if they have a lazy eye, you cover up the other one and force them to use that one until they pay really good attention to it. Paris Hilton has a lazy eye, but it is kind of conjectured that it was, she actually had some sort of damage through drug use, but that's just conjecture. It's on the internet. This isn't my opinion. Acuity problems means you can't focus properly. Well, there are a variety of reasons why these can happen. Dark adaptation just means that you don't switch between the bright cones and the black and white rods properly, and so you lose your night vision. It happens when you get older. You don't see as well at night. Older people get so they don't enjoy driving at night. Retinal detachment means the retina actually breaks loose from the back of the eye, and it doesn't work, if it's not attached. There are attachment processes. They can use lasers and kind of sear it back into position, or they put a balloon in there that rises just like balloons do, and you have to stay in the right position for weeks while the balloon pushes up against the retina and pushes it back into position until it can reattach. Macular degeneration, also called age-related macular degeneration, happens to a lot of old people. And again, because we're living longer, there are a lot more people getting this. And what it is, the macula right in the middle where you see best simply deteriorates. The rods and cones die off, and you don't have central vision anymore. It's like you're holding something right in front of your eyes, You can have peripheral vision to some degree, which is somewhat useful. You might be able to walk somewhere and do something, but you can't really watch TV, or you can't play cards, or you can't read a book. It's, you know, when it gets bad enough, it's essentially blindness. And glaucoma, which is excess pressure in the eye. You can have glaucoma simply because you make too much fluid. It's kind of like hydrocephalus. Or because closed angle, it means that canals of Schlemm have blocked and the exits are blocked and the pressure inside the eye increases. Congenital closure, it just closes up for no reason, or it can be blocked by something, some kind of protein clump or whatever. Glaucoma can cause blindness. It's a leading cause of blindness in the world. The pressure in the eye pushes so hard against the optic nerves and the blood supply for the back of the retina that it kills it. Alterations in accommodation are very common, especially as you become older. Your lens gets stiffer and it won't change shape easily anymore. And so at about age 50, people get presbyopia. Presbyopia, the term presby means old. Presbycusis is hearing loss due to age. Presbyopia, vision loss due to age. Somebody in the medical terminology class said, well, what about Presbyterians? I said, well, what the heck? I looked it up, and Presbyterian, the religion, was created by the elders of the church rather than bishops. The church elders created the religion, and therefore it was called Presbyterianism. So it wasn't a joke. It actually worked out that way. So older people need reading glasses because they can't change their visual distance. And diplopia means that, like, you're looking closer and you can't cross your eyes properly. You know, your eyes have to come in to see something close and have to go this way to straighten out. So you could have an accommodation problem that just was because you couldn't get your eyes to point the same way. You might have to close one eye and just look out of the other one to read. Our normal refraction problems, nearsighted, farsighted. Well, nearsighted, myopia. If you're myopic, I think near, myopia is nearsightedness. Hyperopia is farsightedness. I can see, you know, I can see, myopia, I can see close. That's what I am. I'm myopic, so if I take off my glasses, I can still see up close, but I can't see the far side of the room that well. It's kind of blurry. Where hyperopia is what sailors got. You can see distance, but you can't see up close. It's because you have spent so much of your time looking that way, the lens won't accommodate inward anymore. Presbyopia, of course, means you can't go back and forth because you can't really change and accommodate very well. And astigmatism messes up your refraction. It's an altered shape of the cornea. So it's like your glasses have a little wrinkle in them, and when the light comes through, it messes it up. Most people who are myopic, most Americans anyway, are nearsighted, not farsighted. We look at things close all the time, and our eyes get good at that, get worse and worse at distance. But a lot of us have astigmatisms too. I have one that's more powerful in one eye than the other, and so what they have to do is they have to change the shape of your glasses or your contact lens, or if they do, eye corrective, vision corrective surgery of some kind to change the shape to make up for the fact that you have the astigmatism. So you'll have a correction often for myopia and an astigmatism of some kind. alterations in refraction can become because the lens is shaped wrong, and so it focuses at the wrong place. You know, it's like focusing your projector. You know, if you focus it in too far, it would focus like 3 feet in front of your screen or 3 feet beyond it. But you have to focus right on the screen to get a clear image. So if you focus too close, focus too far. It can also happen if your eyeball is shaped improperly. If your eyeball is a little bit long, you'll focus in front of it. If it's a little bit flattened, you focus behind it. The focus can be off from one eye field. If you remember the way that your eyes work, your vision comes in some parts of the eye, it goes down that part of the optic nerve through that part of the optic eye chasm, chasm, and chiasm. You can lose or have good vision in the right upper, right lower, and left lower eye fields, and they can be different than each other. People can be colorblind. This is a recessive trait, so you know your color blindness you would have to get from a parent who is, you know, homozygous, has both of the recessive traits, or somebody who's you get one from each, you know, person, or something. You have to have both of your genes have to be this trait before you will express it. And that's why most people are not colorblind. Most common is an inability to distinguish red from green. Not a great thing if you're at a traffic light. And most people get sort of an age yellowing of their lens over time. It's not, it's not necessarily clouded, but the color changes. And if they have the lenses replaced for other reasons, a lot of times they'll remark on how vivid and bright the colors suddenly are. It's a long-term thing that, you know, gradually gets worse. I still feel like I see colors as well as I ever did in my 60s. However, if I had my lens changed, I would probably be surprised that the colors would be brighter. Neurologic disorders, you don't have to be an eye specialist, but knowing that you have nerves from this side going in there and from this side of that eye going in there, if I have damage here, I'll only have something go wrong with that eye. If I have damage here, I'll lose the right eye field, upper or lower, upper, middle, lower areas of both eyes. So it's kind of strange the way this works. Both left eye fields go in this side, both right eye fields go in this side, and so depending on where damage might happen, it could affect one eye or both. It goes back to the visual cortex and then up to the processing areas. So you can see, you could lose an entire eye, you could lose this half and that half, or you can lose the whole right or the whole left. Hemaniopia means you've lost one side. Hemi, remember, means one side, like hemiplegia. Other kind of eye diseases, blepharo means eyelid, so blepharitis is an inflammation of the eyelid. We've all had those. Hordeolum is a sty, and it's an infection, starts out usually as a blockage, then an infection of one of the oil glands in the eyelid that help keep your eye lubricated. Conjunctivitis is an inflammation or infection of the conjunctiva, which is a thin layer that covers everything but the cornea and has all of the blood vessels in it. So when you get an inflammation of that, you get pink eye or conjunctivitis, because all of the inflammation causes the capillaries, all the dilation of the blood vessels, and they become very visible. Keratitis is an inflammation of the cornea. Kerato is the term for cornea. So an inflammation of the cornea, an infection. Now, if you can make this go away without scarring, you're okay. If you can't get it to go away without scarring, you're going to need a corneal transplant. And it's from an organ donor, and they take a little cookie cutter, take off the cornea, they take off your cornea, stick their cornea on, and put some little sutures around it. And it hurts for a while until it gets better. They're very successful. One interesting thing about corneas is they don't tend to have the proteins in them that cause rejection. So you don't have to take anti-rejection drugs for a corneal transplant. Vision changes with aging. Macular degeneration, the center part of the eye is degenerating. You're losing rods and cones. Detached retinas just coming loose from the back of the eye. Your lens can yellow, or you can get cloudy spots on your lenses called cataracts. Cataracts happen to a lot of old people. Again, it's an older person disease. We're living longer. A lot of people need cataract surgery. Both of my parents had cataract surgery as they approached age 90. My sister has already had cataract surgery in her 60s. Good chance I will. It's exacerbated by being out in the sun too much, and I've been in the sun my whole life. So what they do is they actually go in, they numb it, and then they go in and they suck out the lens, and they insert a little fake lens in there. It can't change shape, so you have no accommodation anymore. You're always going to need reading glasses. But it's clear, your color improves, and they can actually make the lens to correct your vision pretty well. So if you've been really nearsighted your whole life, like my sister, she had cataract surgery because she had cataracts, but she's never been able to even walk across the room without glasses her whole life, and now she can go out bike riding without glasses. She doesn't have perfect vision because they don't have a way to really do that, but they corrected it about, 90%. I think she has like 20/30 vision without her glasses on now. So that's the eye. Hearing problems. First of all, let's just do a real quick review of the parts of the ear, where they are and what they do. The pinna, the lobe or lobule, the ear canal, external ear canal. This is all the external ear. So otitis externa means an infection out here. The tympanum is the eardrum or tympanic membrane. Middle ear is filled with air, kept equal in pressure by the eustachian tube. You have three ossicles in there, the three bones, the malleus, incus, and stapes, the mallet, the anvil, and the stirrup. And these take the vibrations from the eardrum and transport it to the inner ear through the oval window. There's a membrane there, and it pushes against that. It shakes the fluids in here. You have the cochlea, the shell, which is the hearing mechanism. I think of holding a shell to my ear and hearing the sea. And it will take the vibrations, convert them into action potentials, and send them down the cochlear nerve. The vestibular mechanism is the three semicircular canals. one in the frontal plane, the sagittal plane, and the transverse plane, so you can tell if you're leaning, front, back, side, spinning. This is for equilibrium or your vestibular mechanism. It will take those signals, convert them into action potentials, and send them up the vestibular nerve. They combine to form the vestibulocochlear nerve. One of your cranial nerves, it goes right directly in to the brain. At that point, you have your primary auditory area and your association areas right next to that. Inner ear, once again, you have the ductwork where the fluid goes through. You have little hair-like dendrites almost that stick out, and as the fluid moves across them, it bends them this way and that, and the bending of them causes them to reach a threshold and send the signal, send the action potential. Same way it works up here, but this one discerns frequency, and this discerns movement. So dysfunction can come in a couple of ways. You can have a conductive hearing loss, and this is when the vibrations get here okay, and this is working okay, but there's something wrong in here. These guys get fused together so they can't move, or you're missing one of them. My wife was a competitive swimmer for years and years as a young person. She got so many ear infections they had to remove one of the ossicles. They've tried to put in a prosthesis. It hasn't really worked. But she has a conductive hearing loss in that ear then. She has about an 80% hearing loss. A little bit of sound gets through, but not much. That's a conductive hearing loss. Sensory neural hearing loss means this stuff doesn't work. The cochlea, the hairs in here have deteriorated, the nerve is deteriorated, something's wrong here. So this is all working, but you can't process it properly. Conductive, sensory neural. Presbycusis is age-related hearing loss. People who are old get hard of hearing. From one or both of these, the ossicles kind of get hard, the eardrum doesn't vibrate as easily because it's gotten kind of stiff, or they have fewer hairs in the, sensory hairs in the organ of Corti and the cochlea. Meniere's disease is a separate problem, which it's a pressure fluid movement problem of the fluid inside the vestibular mechanism and the cochlea. The fluid, it gets thicker, it gets too much of it, the pressure's too high. In the semicircular canals, you have what is a kind of sand. It's little tiny bits of calcification that are designed to help move the hairs. If they all wind up getting clumped in one place, they will push against the hairs there all the time and make you feel like you're constantly falling over. It's called vertigo. Meniere's disease produces vertigo. It can produce hearing loss if the fluid isn't moving in the cochlea, and tinnitus, which is constant ringing and buzzing in the ears. I was a rock and roll star for a number of years, stood in front of giant amplifiers a lot, and I have tinnitus now and will for the rest of my life. It's just a constant background ringing in my ears. Ear infections, they can be on the outside, the middle, or the inside. Otitis externa, otitis media, otitis interna. Looking at otitis externa, most common are external ear infections. They may make it all the way to the eardrum, but there are things that can be treated from the outside. Otitis media means it's actually in the middle ear, and especially with effusion, that means it's producing either pus or fluid, and the eardrum will bulge out because of the pressure inside. Ear infections can be really painful, usually treated with antiseptics and antibiotics, maybe antifungals if it's a fungal infection. And age and hearing loss, I kind of went over this. Presbycusis, the hair degeneration in the cochlea. The neurons decrease in number, maybe even in the brain. Your brain shrinks when you get old. Decreased blood supply, or ossification, solidification of the ossicles, so you have a conductive hearing loss. Old people primarily get so they can't hear high frequencies, the fine, fast movements. They can hear the lower stuff reasonably well. So if you're talking to an old person who can't hear you, don't raise the pitch of your voice. Keep it low, keep it loud, keep it clear, and they'll hear you better. Okay, so problems with the sense of smell, olfaction. Cranial nerve 1 is your olfactory nerve. That's your main sense of smell. A little bit from your trigeminal nerve, cranial nerve 5, which gets a few of your sensory cells in there. Olfaction is your main way of differentiating and appreciating taste, because on your tongue all you taste really is sweet, sour, salt, and bitter, and you can tell if something is sweet or sour, but you can't tell the difference between whether it's an apple or a cherry. It's just kind of sweet and sour a little bit, or tart. But if you smell it, then you can tell what it is. So our main reason for needing our sense of smell is so everything tastes good. Different smells that we can detect: camphor, interesting, musky smell, closet that hasn't been opened for long enough, floral, peppermint, ethereal, which I thought sounded really cool until it's the smell of ether, like cleaning solutions, pungent, and putrid. You know, designed to tell you what's good for you and what's not good for you to either breathe or eat. Dysfunction of the olfactory system can be due to a decrease in the number of active taste buds, or the various nerve, not taste buds, olfactory, the sensory mechanism in the roof of your nasal passages, or the signal mechanism of getting them back to your brain, or a decrease in the ability of your brain to interpret them, or you can actually break your optic nerves by hitting your head really hard. It happened to my father, who was in a car accident in his 60s. He hit his head hard, it knocked him out. But your olfactory nerves stick straight forward, and if your brain shakes inside the brain case, it can actually snap those. And he lost his sense of smell for the rest of his life. Hyposmia means not a good ability to smell, reduced ability to smell. Anosmia, no smell, loss of ability to smell. You can also have hallucinations where you suddenly smell something that isn't really there. It's such a complex mechanism of interpretation that people will suddenly smell, oh, that smells like, my baby. That smells like, something I remember from some time in my past. Parosmia means it smells like something else. They smell one thing, but it smells totally different. Taste, very similar. That's why I started talking about taste when I was talking about smell. You have certain things that you can taste. You have more or fewer taste buds and the ability to differentiate better or worse. Gets worse with age. The signals, the interpretation, and the crossover with your sense of smell. Old people lose their sense of taste, but they also lose their sense of smell, so things don't taste as good to them as they get old. Sour, sweet, salty, bitter, and MSG, monosodium glutamate, is actually a distinct different taste used in Asian food. So, a fifth of the world's population uses this all the time. MSG tends to give Westerners headaches, so most Asian restaurants serve non-MSG food these days. Cranial nerve 7. Most of your primary taste is the facial nerves in the front 2/3 of the tongue. Part of 9, even a little bit of cranial nerve 10, the back of your tongue and down your throat. Hypogeusia, decrease. Ageusia, loss of taste. Hyposmia, anosmia. Hypogeusia, ageusia is loss of taste. Parageusia, tastes like something else that it's not supposed to taste like. Could happen because you have damage in your brain, you've had a stroke, you've had an injury, you have a tumor, and you taste something and it tastes entirely different from what it's supposed to taste. So age-related is the most common unless somebody has had, sometimes you'll have a high fever or you'll have some sort of brain damage or dysfunction and will cause your sense of smell or your sense of taste to be altered when you're younger. But most taste and smell changes happen with age. You become less sensitive. You need stronger and stronger flavors for it still to stimulate your tongue very well. And as a result, this is one reason that old people get so you can't get them to eat. They need to drink, they need to eat, their thirst mechanism is decreased, and nothing tastes good, and so they shrivel away while you're trying to get them just to eat enough to keep themselves healthy. And because there's no other really good place to put it, we're going to talk briefly about sensory dysfunction from just general sensory nerves. Sensation. So you have to, is it pressure? Is it heat? Is it cold? Is it wind blowing over it? Is it pain? What kind of sensation is coming in? Duration, intensity, present in the skin. Generally, you only lose sensation on the skin if you have nerve damage. Remember, it's the same nerve that innervates this muscle is going to have afferents that branch out into the skin. So if you damage your radial nerve, not only will you not be able to extend your hand and fingers properly, but you may have some numbness on those above those muscles where that happens. Proprioception can be decreased the same way. You can have a decrease in proprioception due to things like ALS or other neurological diseases, or it can be damage to nerves, or it can be a damage to the inner ear, which is your vestibular mechanism, or the cerebellum, which houses proprioception. Damage to the cerebellum. If you have vertigo, you also may lose some proprioception. Meniere disease, which causes vertigo in itself.